Can you hear me now?
Yes.
Okay. Phew, good. Thank you. So, thanks everyone for inviting us. Oh, Mary Kay, you have your hand up.
Yeah. So Kathy, before Lynette, you get started, you said there's 7 counties that didn't have it, Portage and Wood, which seems like they would be strong enough to have it, and a few others. And then it's gone down almost 2,000 people. Do you have any insight into A, why those counties don't have it, and B, why the numbers are down?
I'll start with why the numbers are down. In my mind, there's a sort of obvious answer, and then I'm sure there's other factors. But when DHS fully funded comprehensive community services programs in 2014, the promise was from the counties and from DHS that this would not undermine CSP. However, it did. It did. Many counties chose to move people to CSP from CSP to CCS to sort of stop covertly offering CSP, if you will. I don't know how else to say it diplomatically, but I think CCS is a big factor in why less people participate in CSP. The problem with that is CCS is there's not an evidence-based practice prescribed by the administrative rule. So it's sort of more a brokering of services and hope that you get what you need rather than the ACT model that Lynette will tell us about. And why some counties choose not to? I mean, first of all, I have to say, I don't know. I can't speak for those other counties, but my educated guess is going to be CSP teams are not, they're relatively expensive. So it takes some county levy in there. It takes a lot of support from your county board. On the other hand, I will say, and we had data in Jefferson County to show that they save a huge amount of money when it's done right. So I guess the short version is I'm not sure why some counties don't do it. I would argue stridently that everyone needs to do it and do it right. But it seems to have to do with the support from your county board and sort of what your leadership is going to ask for and advocate for, quite honestly.
And just to clarify, then let's go to Lynette, but CCS is actually, they reimburse fully where they don't for CSP, which makes counties probably more likely to go with CCS because it is fully refunded versus CSP, correct?
That's correct. In CCS, there's initial county property tax dollars, so tax levy from counties. There are some in there in your startup of CCS, although you recoup that at reconciliation. So it'll be fully funded by the federal Medicaid portion, and then the non-federal portion is funded by state GPR. And community support programs, it's funded by whatever the federal Medicaid share is, roughly around 60%, 59%. And then the rest is funded by the cost reconciliation process known as WMCR and county tax dollars. And I'll just put in my own editorial comment and say, if you're not very good at cost reconciliation and WMCR, then you're going to lose out even more on money for funding your community support program.
Thanks. Thanks, everyone. So I'm just going to jump in. And these are the 4 points that CETA asked me to try to touch on. So I'm going to go through this pretty quick to save time for questions that people might have. So the description of the CSP, this is straight out of the statute. One problem with our statute is that it was created in 1989 and it has not gone through any significant updates. And so you can imagine with the movement that we've had in the mental health treatment realm, and we don't even use person first language in this statute, right? With kind of the stigmatizing language that is still there. But the programs were originally set up for people with mental illness living in the community. And the purpose per statute is to provide effective and easily accessible treatment, rehab, and support services in the community where persons with chronic mental illnesses live and work. So the idea where sometimes the ACT model is called the hospital without walls. So the idea was to pick up a hospital unit, put it into the community where people are experiencing barriers and to try to problem solve that in real time. So that is our definition of CSP. How we evolved to this, and I'm not going to go deep into the history. There is an amazing video from the PACT program that kind of goes through the 50 years of evolution of PACT and the model. Developed in 72 through Mendota Mental Health. And really the main problem they were trying to address was the revolving door of recidivism with people that were really ready for discharge. They had a great discharge plan set up for them. And then they would come back a lot of times based on how fragmented the system was or just challenging to negotiate. So they decided to move into the community to follow clients and to help them there. In 1974, they won the APA Gold Award for their research, and they were actually involved in a longitudinal 7-year research project. But they were the outcomes were so amazing that they actually stopped some of that trial, and NIMH wanted them to take this intervention straight to dissemination. So there was a lot of evidence around it. These are just kind of Wisconsin specific evolutions of CSP along the way. Really kind of starting in the 80s, the early 80s is when the state got on board to assist with the development of the CSP administrative code. They developed what was called a CTT curriculum, which was trying to disseminate knowledge to individuals that would lead the programs. And then Wisconsin was the first state in the country that figured out how to get CSP Medicaid reimbursable. So Debbie Allness was very instrumental in that through the Office of Medicaid, and really Wisconsin became a leader in getting CSP and ACT services Medicaid reimbursable. So it really became kind of a Medicaid program in a lot of ways in Wisconsin. And then the next state that it disseminated to in the 80s was Michigan. And then since then, it has disseminated nationwide and internationally. There's only 3 states in the United States that don't have assertive community treatment teams. Wyoming, Hawaii, and North Dakota are the 3 teams that don't have any ACT teams, but the rest of them do. So with assertive community treatment, how it's a little bit different than CSP, how it's evolved in other places, is that it takes the lower intensity community-based services, along with more restrictive settings and more intensive acute work, if those things are needed by the client, and it's a one-stop shop, right? So the original idea was really about decreasing the fragmentation of the system so that clients didn't reach or get any of those barriers. And so ACT really does this. If you look at most of our CSPs right now, you're going to find that they do an okay job with some of these lower intensity community-based services. A lot of them have become very heavy on the med management part, a little less on the rehabilitation part and crisis services. So an assertive community treatment was initially created to be a 24/7 program. So it didn't matter the time of day or if it was a weekend, staff were available to clients. In our current CSP system, a lot of times most programs now farm out crisis services. So they shut their office at 4:30 and then the client is kind of left to the current county-based crisis related system, which just goes to, again, reinforce kind of the fragmentation that can happen. From a research perspective, assertive community treatment is one of the best service delivery models that has over 25 randomized controlled trials. So we're really solid with the evidence around assertive community treatment. The most robust outcomes are a decrease in hospital use, more independent living and housing stability for folks, retention and treatment, and then client and family satisfaction. So these are kind of the uncontested outcomes of assertive community treatment. There can be other outcomes, and it's a little more mixed in regards to the evidence around things like the ability to gain and sustain competitive employment, a reduction in legal involvement with clients, but those are a little, there's mixed evidence around some of those. So I wouldn't put them in the most robust, but good programs can have really high employment rates. The national data shows that 8% of clients will get jobs on their own in a CSP. And when a good ACT team is working the employment component well, their competitive employment rate can be between 40 and 50%. So there's some good trend data out there. Factors that lead to better outcomes, what we look at in the ACT world is really around this issue of fidelity, where the research shows that the closer that ACT programs stick to the basic ingredients of assertive community treatment, the more likely they're going to have more robust outcomes. And as you start to change that or adapt it, the term we use is fidelity drift. So teams that have higher fidelity drift tend to not recognize those robust outcomes as well. The most widely accepted fidelity tool is called the TMAC, the tool for measuring assertive community treatment. I have a link in here. I can certainly get the presentation out to CETA if people are really interested in diving into that. But in a really kind of overview, there are 47 items, 47 kind of ingredients of an ACT team. And the closer that teams get to doing those 47 components well, the better the outcomes are going to be. So there's 6 everything is rated on a 1 to 5 scale. A 5.0 would be a perfect ACT team. In the almost hundreds of evaluations I've done on ACT teams, I've never seen a 5.0, but we really celebrate when teams are over, a 4.2, 4.3. There are 6 subscales in the operations and structure, core team, specialist team. So within this are 47 components across these 6 kind of subscales. So you can see they're really looking at person-centered planning. Let me go back, sorry. The core team is, do they have enough psychiatry time? Are there nurses? Is there a team lead? Specialist teams, or do they have individuals with expertise in certain areas, such as co-occurring substance use, employment? Is there a peer support specialists that are on these teams? So for teams that are getting consistent fidelity ratings, this can be a really great quality improvement tool. And one of the things that the state of Wisconsin has done since 2021 is to engage through a voluntary method teams that want to be, CSP teams that want to be reviewed against this ACT scale to give us a sense of what are the needs in Wisconsin CSPs and how close are they aligning with the assertive community treatment model. So here's kind of how we're doing. This is de-identified data from Wisconsin across the teams that have volunteered. So since 2021, we've had these 10 teams, which we're very grateful for. And you can see that our scores range anywhere from a 2.48 up to a 3.15. In other states and internationally, The cutoff for an ACT team is a 3.0. So any team that scores less than a 3.0, we say, you know, you might be having a really great program, but it doesn't look like an ACT program. And so this data speaks really largely because it shows that out of the 10 teams that we've reviewed, only 2 have made it above that 3.0 threshold, and not by very much. And these are good teams. That doesn't mean that they're providing poor services. It just means that over the course of decades, we haven't had a system that's reinvested in assertive community treatment. And so these teams have not had the resources to be able to continue up and to do assertive community treatment in the way they've needed to. We hypothesize that these are the best teams, some of the best teams that we have in Wisconsin, because they're self-selecting in to be evaluated. So we don't have the teams who are saying, no, please don't come here. And we're assuming that they're probably going to be a little bit lower on this scale than these teams that really so graciously invited us into their programs. So the lowest subscales, if you go back and look at those 6 areas, the lowest that Wisconsin is scoring is in this specialty team area, and in the evidence-based practices area, and in person-centered planning. So those are the 3 real opportunities that we have in Wisconsin that would give us the most bang for the buck as far as what would we need to do in order to get the outcomes that we're looking for. And those subscales are really looking at specialists on the team. So it makes a lot of sense. When Wisconsin started their CSPs, we were known for being generalists. Like, that was really the idea, that there should be no single person that's an expert on the team. Everybody should be able to work with everybody. And so, which is great. You need that. You're not going to have a co-occurring person that says, oh, I'm sorry, that's not my area. You're going to have to go talk to another team member, right? We wanted people to be able to step in with anything. But through that, we've diluted people's expertise. And so when we have a need for a real good co-occurring specialist that they can come in and really help a person get off meth or do harm reduction around their crack use, we have really great generalists and not always really great specialists anymore. So if we could focus on getting more specialists on the team, and then really integrating evidence-based practices into the work of the CSP. So making sure they know about supported employment and that they can deliver supported employment services, providing psychotherapy within the team instead of having staff or clients have to go out and get psychotherapy from outside entities. Part of the cost savings of CSP and ACT, like Kathi was saying, studies show that economically it's a break even. CSP and ACT doesn't cost more if it's done correctly. But part of that was because things weren't farmed out. So you had an internal therapist. It costs a lot to have that therapist on the team, but you were preventing a client or 60 of your clients from needing to utilize outpatient sources for that therapy. But since there's that kind of fragmentation now, the system continues to be a little more overloaded because the majority of CSP clients are going out to seek outside therapy services because there's not a clinician internal to the team that can provide that. Right. So just some recommendations, and I know that I'm going through this really fast, so I'm happy to answer questions, but some recommendations, and these are my own opinions, so I want to own that. And it's based on some of my work. I was in the state of Minnesota at the DHS, where we also were looking at reinventing our assertive community treatment program. So I love that full funding for CSPs is on the table. That absolutely needs to happen. And I believe that not all CSPs will become ACT teams. I think that there is room in the service continuum for both. And so I think I'm not suggesting that every CSP should turn over into an ACT team. However, I do feel like for those teams that are striving for that level of care, there should be a clear path for them to be able to provide those assertive community treatment services. My biggest worry is that if we get the full funding for CSPs, that there will not be a reinvestment in the CSPs, but that instead that 40% that counties are saving are going to go to other areas where they need those monies, maybe unfunded mandates, things like that. And then I feel like we've missed an opportunity that along with the full funding, we should have some plan to engage the CSP stakeholders to figure out how does that money get reinvested into the CSPs so they can move forward towards more ACT fidelity, that would also provide them with some technical assistance. And then also the statutes either need to be reworked or maybe created for an ACT path and a CSP path, but definitely there's got to be some changes in the statute so that it supports the teams and protects the teams in regards to the work of the evidence-based practice. So those would, those are kind of my two areas of recommendation and just kind of concerns that I have if CSPs just get full funding and there's not other discussion around reinvestment in those programs. So I'm going to stop there. And, please ask any questions or any points of clarity that I can do better on.
Thanks so much, Lynette. Maybe you could stop sharing slides and we could have a little bit of a discussion and then go on to Kathi. So I'll just open it up to other folks who has questions specifically on what Lynette has presented, just like points of clarification, and then we'll ask Kathi to present and then we'll have a general discussion.
Peter has a question.
Go ahead, Peter.
Lynette, what you presented, how much of the data takes into account the involuntary?
Do you mean consumers that are involuntarily committed into the programs?
Correct. I
Okay.
mean, those that, like I'm a family that's dealing with one that, I don't want to go much into it, but my biggest concern is the criteria that's used is so high that they criminalize people like my son, rather than getting them into a treatment program. And I can speak from experience.
Yeah.
So my question is, are the numbers you're presenting and that Kathi presented, do they include all of those that are involuntary? Because one of the things I've seen in listening to a lot of data sent out is it doesn't take into account the involuntaries that are out there and are not being included in the numbers that, people are hospitalized or going in, they make the choice, or a family member convinces them, or the police convince them to be voluntary.
Yeah. Thanks so much for the question. So the data includes individuals that are also involuntarily committed to CSPs or with assertive community treatment. So actually the ACT model doesn't shy away from individuals that are under any kind of assisted outpatient treatment orders. In fact, it's kind of seen like ACT teams are the perfect place for individuals that have kind of those co-occurring and intersectionalities of criminal, legal history based on mental health and substance use and all of that. So the numbers that I reported, and with the majority of data studies from the 80s on, do include people that might be under an involuntary commitment or have guardians who are signing, kind of reinforcing that they have to be involved in ACT. So My numbers do. Kathy, I'm assuming yours do too, but I don't want to speak for you.
Yes, Jefferson County's numbers would have included every participant, irregardless of whether you were there of your own free will or because you're on a 51. I don't mean to take us off on a tangent, but I'll just, will mention this because I think everyone should know it's an option out there. At Jefferson County for over 30 years, it was not law enforcement taking people into custody for purposes of an emergency detention. We sent a person on scene, a trained mental health worker who happened to be certified in intake 938 and under 51, that was allowed for that person to take the person into custody. So it was the Human Service Department taking people into custody rather than law enforcement. We really believe that was important because these are healthcare issues, not law enforcement. And because we were doing that and on scene, we could divert a number, a pretty high number at the time to voluntary services and get people in pretty quickly. But anyways, to answer your question, yes, it absolutely included anyone who touched CSP services.
Can I ask real quick a follow-up? I don't want to dominate this, but my problem though becomes in these numbers is that they're not taking into account, like in Milwaukee, we had 7 incidents at my house in a 7-month period where the police were involved. There was only 2 cart incidences, neither because whatever, well, I can tell you, Sam goes into his playing dead routine and then he gets a little better and they don't take him away because he's not in the moment of committing a crime, because that's the criteria in Milwaukee. It's imminent danger to themselves or someone else. So in essence, they have to be committing a crime. Either it's upon themselves or someone else. If they're not caught in the moment, the police aren't taking them away. It's not happening. So all these numbers you have do not take into account all the people like my son. And there's a lot of them out there. That's how Admire started as a family advocating group, is that we got tired of listening to everybody go, well, no, they don't fit. But yet they're ready to take them to jail, because I guarantee you they would have taken my son more than the one time they took, and they cut him loose in hours. And I don't want to talk about my situation. I'm just trying to share that those numbers, I don't think they account for all the people that are out there that are suffering.
Let Kathi and Lynette respond.
I'm not sure what is helpful, but I will say this: when CSP, when Community Support Program, or when an ACT team is done, again, unquote, quote unquote, right, or what I consider to be right, one of the key tenets would be continuous, persistent offering of treatment and finding a way to reach out to that person and connect with them, irregardless of whether they're committing a crime, have committed a crime, incarcerated or not. So, I mean, I don't mean to be tongue-in-cheek or patronizing here, but some of our contacts started out with, let's get you a meal and something that you really like to drink. And in other words, when it mentions the person-centeredness, that is really key. Meeting the person where they're at, forging that connection, and then persisting, never giving up, like walking alongside the person and never giving up. Presenting that hope, presenting options, engaging with the person and finding a way together and beginning sort of that wraparound of services.
Thanks, Kat. Oh, go ahead, Mary. Okay.
Sorry, so Peter, if your loved one is in an ACT program, the really cool thing about it is you wouldn't call police, you would call their caseworker that's in the ACT program first. And that caseworker would be the one that would show up at your door, not the law enforcement. Only in a situation where the caseworker and everyone in that ACT program felt it was of great concern that they needed to call law enforcement would they ever go that route. So the nice thing about ACT programs is you have a caseworker, you have a psychologist, a psychiatrist, all of this team that wrap around and takes care of your loved one. So you don't have, your first call would never be to 911. Your first call would be to their caseworker in that ACT program, because that's the response to your the person that's in that program. It's just a unique program where the goal is to kind of decrease the amount of law enforcement that's involved and increase the relationship that the loved ones built with and the families built with that ACT program. And sorry, Lynette, go ahead. I just wanted to.
Yeah, no, thanks with that. The only thing that I would add is that in an assertive community treatment program, services expand and contract to what your loved one needs. So there were times when we would see a client 30 times a week because they were in crisis and the team needed to go out 3 times a day or 4 times a day, and just to check in or to, help the family take an hour off or whatever it was. And so that service expansion and contracting really is part of the model. The CSPs here don't have the ability to expand and contract the way the original model was intended to be. And so that's part of the problem too. Like CSPs, they might shut their doors at 4:30 and then it goes to crisis. But in an ACT model of care, you would, as a family member, you would never not be able to get a hold of a member of that team who will come out at any time of day or night to problem solve it, so that the person doesn't have to be involved in law enforcement, or maybe doesn't have to go to the hospital. We can try to figure out a crisis respite situation or something like that. So
yeah. So in our heyday and our best days of the program, so to speak, we would see people on the weekends. We would help them get to church. We would figure out a plan for all those transition times, whatever peak stress there was for the person or the family or the whoever was living in the home. And we, as Lynette said, we would titrate up and titrate services up and down based on those needs and presenting needs at the time.
The only problem is there's not any program in Milwaukee that fits what you're talking about. None.
Right, and that's why we're doing what we're doing. So Kathi, why don't you go ahead and just tell us what else you want to tell us, and then we'll have a general discussion.
Sure. I'm not sure I have a whole lot else to add. I will say there are serious workforce issues right now. That's partly why additional funding is needed. There's also serious workforce issues, though, because somehow we're missing the people, the students. Maybe Lynette can share some insight on this, that really kind of share these values. I remember hearing Debbie Allness talk, and to this day, I still get a shiver, because she would talk about this CSP is about social justice. CSP is about everybody having a fair and equal chance. And we seem to somehow be missing the ability to find those workers and team members that still hold those values very dear. Somehow we have to do a better job about that. Part of this, again, goes back to funding. I think we also need some more oversight. Lynette mentioned the issue, if additional funding came in, what would happen to the tax levy that's already in there? Maintenance of effort has been established. When the state fully funded children's long-term care waivers, the counties were held to a certain amount of keeping that money in there. It also happened in 2017 when we got additional money from the state for crisis funding. So that money needs to stay with mental health, no question about it. So I'll stop there, I guess.
Thanks, Kathi.
Sure.
So I guess I'd like to do a follow-up question on that. I gather that there were some problems with the requirement for maintenance of effort for crisis funding. And how can we require maintenance of effort in the recommendations that we make, or encourage the state to require maintenance of effort without running into the problems that they ran into with crisis maintenance effort?
Well, crisis, we got it through. And part of the crisis formula it was complicated. And just to be very frank, because I was very involved in that at the time, a lot of counties didn't understand it. Some of them didn't even realize it had happened. So I'm not trying to be unfair, but that is just part of what happened. So I think to make it happen, we have to do a lot of education with county boards. I mean, usually when your human service leader is saying no to maintenance of effort, it's because it's been a directive from their oversight board. So educating the board, educating county administrators about why this is important, and that this money doesn't go somewhere else is sort of the key. So, but also having really good examples and really clear examples of how this really, what the whole transaction looks like. I think that's one of the mistakes we made in the crisis. Like, we were also happy to get it, that we didn't have clarity in the examples of how the funding would really work. So, in hindsight anyways, so. Another piece to maybe think about as we sort of think about the cascade, if this were to come to fruition, is family care. With the advent of family care, CSP had to get parceled out, and you have to get an authorization for different parts of CSP, of the community support program, from the managed care agency. And oftentimes there's a sort of it takes a lot of advocacy to get that authorization from the managed care organization, which is exasperating, to be frank. So somehow that sort of needs to change, and further education and getting all those stakeholders on board too.
Did that parceling out take, did that fall into people who were in Badger care as well as people who were in family care, or just family care?
Just family care. Mm-hmm. Yeah, because the family care benefit included parts, it included case management and psychotherapy, which are covered under a community support program.
And then one thought about the workforce shortage and people who are not going into community mental health was, if it is the full ACT model, then it's much more fulfilling than if everybody's a generalist, like Lynette is talking about. Lynette, can you speak to that?
Yeah, like, so I'm in a position here at the School of Social Work where I get to touch all of the graduates that are getting ready to go out into the mental health field. And one thing that I consistently hear is that people can't do therapy in CSPs. So they look to go to outpatient settings or private practices to do those things. And in some ways, in some of the CSPs, that's true. But there's also this perception of that the work is too hard or too unfulfilling. Some of that is around the misperceptions around serious mental illness and what can or can't happen. But there's kind of this perception. I don't have any student coming into me to say, I can't wait to work with within the CSP system. And so I think some of it is showing that there can be specialties within the assertive community treatment model, in that people are really well poised and trained to be a specialist and a generalist, right? Because back to Kathy's issue of social justice, you're going to have to help people start from where they're at. And sometimes that that might not be your specialty. It might be something else that they need. And so, the other thing I think that is hard is that CSPs are competing with just other programs that have the ability to pay better or give better benefits. And right now it's the students' market because of all of the openings. And so in some ways, I feel like that's part of the issue too, that if we could pay similar, if CSPs could pay similar to what inpatient clinical social worker is making, at least it would even the playing field a little bit. But right now, community, especially county-based work, is just seen as not as desirable as it might have once been. So I had more students this year accept jobs in CCSs because they could set their own hours and they could negotiate their own pay. And it's really marketed as a better work-life balance. And I think CSPs could attract the same amount. There can be good work-life balance in a CSP. You actually get benefits, where in CCSs, if you're independent, you might not get benefits. But the pay has to at least be equal to some of these other community-based services, or students just won't even give a second chance at looking at it.
Thanks, Lynette. Cheryl, I'll turn it back over to you. I realize that I've
Okay,
done
well,
much of-
Lynette, there was a question from Mary Kay that if we defined CSP to require X, Y, and Z of the ACT program, would that help? Literally defining what CSP has to be.
Yeah. I think it would. So my experience in working with Minnesota, it took us a year, but we brought all the important stakeholders to the table, and we had meetings every 2 months where we literally wrote the statutes kind of together, so that we could work out the challenges before we presented anything. And that seemed to work out pretty well. And we were very explicit. We were very explicit with, we did teams that were small, medium, and large, and we made parameters around what each one of those teams, how they had to have staffing, how they had to offer different services, what those services needed to look like, their hours of operation that they needed to be open. And then I think that was helpful. It was a helpful roadmap for stakeholders where they got that input, but it also protected them in a lot of ways also from other pressures from the agency. Because if an agency says, well, we're just not going to pay you to be open past 4:30, there was a statute that actually said, no, this program, we have to be open past 4:30. So let's figure it out. So you know, the challenge with writing that policy, I don't have to tell you that, Mary Kay, is like, you want to be explicit, but you want to have flexibility within it as well, so you don't kind of back yourself into a corner. But I really liked that process. It was not easy because different stakeholders come with different lenses, and it was not an easy thing, but it was so worth it because it had full backing by the time by the time we were able to present it and get it into law.
And do the Minnesota teams that, like, do you have an evaluation on their rankings, their ACT program rankings based on those criteria?
Yes, they had to go through a serial fidelity review anywhere from every year to 3 years. So if a team was doing really well, we didn't come back until the 3rd year. If a team was really struggling, or we felt like the client care was really substandard for whatever reason, we would probably come back in a year. And then the quality assurance plan included fidelity measurements. So if their planning was really poor with clients, we would say, we want to see an increase in this score, and tell us, what do you need in order to get to that point? What resources can we put into that? It also helped us as a state to figure out what were the points that lots of teams were struggling with, and how we could do better with communicating and training folks around those particular points. I gotta say, the biggest strength that Wisconsin has is the amazing CSP teams dedication to wanting to do better. Like, I've just been so impressed and inspired because, you know, teams are like, yeah, we really want to do this. So help us get to that. But yeah, we did most states that have teams that better meet the evidence-based practice do some form of fidelity monitoring on a schedule. And their Medicaid was tied to it. So if a team consistently scored under the 3.0, we were no longer going to give them ACT funding, because we were worried as a state that they weren't giving ACT services and that it could come back to us where the feds wanted their money back. And so we were pretty strict with, like, this is our minimum, that, you know, and we wrote our standard not to the minimum, but to the evidence-based practice. And I hear that's different in Wisconsin. A lot of times statutes are written to the bare minimum, which in an evidence-based practice, it's pretty hard to write it to a minimum, I think. So that would kind of be the other difference that I hear between Wisconsin and Minnesota as far as writing administrative code.
To sort of state a couple, or reinforce a couple of obvious things Lynette just said, there is that all kind of oversight and really high quality technical assistance is really, really key. we somewhere along the way here, the last 20 years, we lost all of that. It's really, really key to have that. It would have been really helpful to have that when the opioid epidemic hit or when meth first hit. Those two epidemics, huge factors. They overwhelmed all of us. And I guess the other thing I want to emphasize is flexibility, even though I'm saying there has to be a rigorous standard and technical assistance and feet really held to the fire to get it right this time. I'm also going to say that flexibility is really key too. There are 72 counties, like we just heard. There are some real differences. But you know, if you tell a county what they need to do and allow them some room to get there, it can work. So some of those small counties are going to have a hard time having ACT teams, but maybe there's a way they can jointly across a region have an ACT team or something. I mean, there's ways to figure those things out.
Lynette, isn't the reason it works in Minnesota because you're all Scandinavians? Instead of Germans, like we
Well,
are?
that's in northern Wisconsin, shouldn't it?
I know, that should fit here then too, right? I tell you though, one thing I learned,
You're
Peter,
all a bunch of socialists in Minnesota.
there was a Minnesota nice kind of a vibe that I had to work around too. It was not always nice, it was direct, and that wasn't always the best either, but that's funny. It probably had something to do with it, Peter, probably.
Are there other folks with questions who haven't spoken yet?
Well, I had a question about workforce. You mentioned that many people don't want to go into that area. And if there's workforce turnover, which I've observed in my family members' treatment, doesn't that really adversely affect the success of their treatment?
Yes, resoundingly it does. I mean, to have to restart with someone and tell your story again and sort of catch your new team member up to speed is painful and grooming and leads to setbacks. Yes, it's a huge factor.
So somehow getting it more attractive and finding the people who would be willing to be in that setting seems to be a priority.
Yeah, absolutely. I like what I said, part of it is the pay. The hospital systems are paying a lot of money to be a vendor for CCS, with the CCS rates, given what they are, pay a lot of money. CSP at the county level, as a county worker and a CSP, you're not going to make comparatively anywhere near what those two other factions are making. So that's part of it. Part of it is like we're talking about the training. I mean, when we're all human beings, and what do we tend to avoid? We avoid things that are stressful. So when we don't know what to do, if we're in a CSP program that doesn't have a good training program or the roadmap to ACT or an ACT team, and it becomes very stressful, as it will, we want to leave. We want to avoid that kind of work. So I think solving those two things, yeah.
Karen has a question, I think.
So are there any counties in Wisconsin where this is actually working? Because I know I'm in Green Bay and we do have the CSP program, and my son is actually part of that program, and it is absolutely not happening like that. And I would love that. And where could he move to?
Great question. The hope is that I'll be able to say yes in a while. You know, actually, probably the closest that we have to assertive community treatment is the original program, which is in Madison. The very, you know, we call it the mothership, the very first one that started. And then there are some other CSPs that have worked really hard to stay as close as they can. So Jefferson County was definitely one of those. The programs in Rock County that we've seen are probably some of the state's best. But again, I've only seen 10 out of the 70s. So there could be other programs that are doing well that I just haven't been able to see yet. So yeah, it is one of those things too, where we did a cost analysis, and we really felt like with an ACT team, the lowest census that a county could have of clients is around between 30 and 35. But anything less than 30 clients, it really becomes less fiscally viable. And so, you know, that would be a consideration too, as we're looking at the spread in Wisconsin. But I think it can be done. I mean, I'm really hopeful. I think we could attract more people into the behavioral health workforce if we can, like, they're worried about burnout, but when you're working on a transdisciplinary team that always has somebody available, the burnout actually becomes less, because I can go home and I know that my colleague is going to treat my client as well as I would treat them at 11 o'clock at night when they're in crisis. And like, there's just some really beautiful things when this model is working. It isn't about burnout and drudgery and all of that. It's like, it's such an honor to walk with somebody on their path of recovery and to be able to help that. That's like a really cherished thing. And so I think there's ways that we can start to remessage it. And if people like Kathi and I, who've been in the field, we did the work, and I agree, it's the best work I've ever done. Could I do it now at my age? I don't know, but it was great. And so I think that we'll be able to turn some of that, but we can't keep sending students into these CSPs where it isn't working as well. Like you, Karen, and Peter have already kind of said, that's not what I'm seeing my kids being in. And so, you know, students go into that and they're like, this is not what I want. But if the program was operating the way it would be, I think we could really hook a lot more students into spending a fair chunk of their career into this area. So
I just have to echo that. It was the most rewarding thing I ever got to do. I was fortunate that someone, a CSP program, contracted with me for a few months while they were really short staffed late last year. Again, it was fun. It was exciting. It was rewarding. I mean, if you can go in there with some skills and some can-do beliefs, and then really have that support and supervision about what you need to learn and do, I mean, you're part of a transformation in someone's life. What can be more special? So,
Sita, I think you want to wrap it up probably here.
Well, yes, and but I have a question about it. Lynette, in Minnesota, did you do multi-county ACT teams? Or I'll ask Kathi the same thing. And how well did that work? What?
we did. There were a couple. There were a couple of multi-county ACT teams. One example I can think of that went really well, and one that didn't. So the one that went really well, it was a 5-county consortium, and there was one county that was more populated than the other 4, but there were still clientele in all the other 4. And they had to adapt a little bit by having a higher, more staff, because some staff were driving 3 hours one way to see a client. And when we were talking about that expansion and contracting or titrating up contacts, you still have to be available to that person 3 hours away, 3 times or 4 times a day if that's what's required. So they had a higher staffing ratio to be able to cover the actual geographic distance. In another program, they had only 2 counties, but they were more spread equally, and that was more of a challenge. It was far more windshield time. And that was a bit more of a challenge. The amount of space that they had to cover made it very, very difficult. And so lesson learned that we would probably have said, you know, not these 4 counties, but we'll do 2, how about 2 teams and 2 counties apiece, and let's see how that goes. So, but we did see it, and we did have a team that started with only 32 clients, and everybody told us that that couldn't be done, but they did an amazing job, and those 32 clients really received top-notch care. So when people say it's got to have a certain amount of clients, I think that's true, but I think for those of us living in a rural place, we can get creative and serve even a smaller amount of people, but still make it fiscally viable and person-centered.
and there are 11 joint CSPs in Wisconsin. There's 4 different sites. So there's like Forest and Ida and Vilas, and then Marathon Lincoln and Langlade, Grant in Iowa, and I think the other one is Chippewa, Pepin, and Buffalo. So there are multi-counties organized into one CSP program already, so it can be done. The Grant in Iowa have a long tradition of doing that, and the Human Service Center for Oneida and Violas had a long tradition. I think that's currently being dissolved or has been dissolved though, but.
Thank you, Kathi, and thank you both so much for sharing all of this with us. And just for everybody else, we will be advocating again for full state funding of CSP, but I think we will run this letter past you all and other experts to make sure that we have enough teeth in this thing, that if we do get our $45 million, it is going to be well spent and effective for the people in care. And with that, I'll turn it over to Cheryl.
Oh, thank you very much, Kathi and Lynette, for helping us understand this better today, and we appreciate your time. Thank you so much.
Sure. Thank you for taking up the charge. We greatly appreciate it. Thank you.
Thanks for the advocacy. You're amazing. Thank you.
Yeah.
Okay, I don't have any federal policy updates to bring, and are there any committee members who have any announcements they would like to make?
I think just a reminder that we will not have a PP&A meeting next month. We take July off. So there won't be an email. Would be important to remind everybody. I know Sita said at the beginning, but I just want to remind folks.
Is there anybody else?
And then if anybody has questions or thoughts about CSP that you want to get to Lynette and Kathi, send them to Julia and me, and we will forward them.
And I do have on here Sita, the MHAP stakeholder collaboration update, but I think you've already covered that, haven't you?
Yeah,
Okay.
I kind of did. And Mary Kay. Yeah.
Right, the two of you. So with that, I believe we have covered everything we intended to, and I appreciate everybody's attendance today, and have a happy remaining June and July, and we will meet again in August. I think it's August 5th. So thank you very much.
Thanks, everyone. See you.